Okay. Hi, everyone. Thank you so much for joining us. We will get started in a minute or so, waiting for some folks to join. All right. Hi, everyone. Thank you so much for joining us. We are so excited to have you here. If you want to introduce yourself in the chat, since we have some folks joining us from outside of California, thank you for being here. We're really excited to have you. And we will go ahead and get started here in a minute. All right, we've got a good number of folks. All right, I'll go ahead and get started. Hi, everyone. Thank you so much for joining us. My name is Savannah Gray. I am the Clinical Program Manager at CMQCC, and we are starting the first of our series in the Lessons from the Learning Initiative, exploring some promising engagement practices out of this collaborative that we are having ongoing at the moment. Today's session is titled Doula Partnership and Team Engagement, Building Blocks of Culture Change, and we're really excited to get started. Some housekeeping things. All of you will be muted upon entry. Please utilize the chat feature if you have any questions or comments. We will be fielding them as we go. We also have a live Q&A. So we'll be doing our best to answer the questions during the webinar, but we will also have some time for Q&A at the end. Please don't copy the slides. If you'd like to use any of the information, please reach out to us directly. And we welcome your feedback. We are always looking for recommendations for future webinars, ways to improve, things you guys would like to learn. So please feel free to reach out and let us know what you think. The webinar recording and the slides will be posted at cmqcc.org within the next 48 hours. Both the recording and the slides will be available. And a brief look at our agenda. We'll be providing an introduction to what the Learning Initiative is, and then having some presentations by two of our participating hospitals, both Enloe Medical Center and University of San Francisco Medical Center with their partnership through SisterWeb, and then have some time for Q&A at the end. We'll have about 15 minutes or so of Q&A, so please feel free to utilize the chat. We'll be holding on to those questions until we get to the end. So to get started, introduction to the Learning Initiative. The Learning Initiative is a CMQCC quality collaborative, a little bit of a different form of collaborative than what we've done in the past, where we are really focusing on shared learning experiences, shared opportunities to learn from hospitals rather than focusing on a standard of care or standard of quality. We are funded by the CDC from starting in 2022 through 2027. So we are looking at 5 cohorts, 5 rounds of hospitals participating with us. Each collaborative cohort is about 18 months long. It's a little bit longer than collaboratives that CMQCC has done in the past, and really diving into the material developed through CMQCC's Supporting Vaginal Birth Collaborative that began in 2017, and our pilot birth equity collaborative that was started in 2019. We're taking the lessons, the curriculum, the education from both of these collaboratives and sort of combining them, built on the feedback that we received from hospitals and some of the recent maternal mortality and morbidity reviews that have happened since then. The overall goal of the Learning Initiative is focusing on reducing disparity gaps in low-risk cesareans with the goal of all patient groups reaching or exceeding the Healthy People 2030 target rate of 23.6. That's our overall aim, looking at those two pieces of disparities and low-risk cesarean rates. A little bit more detailed goals are, again, looking at these NTSB cesarean rates, trying to make sure that we're getting hospitals to that 23.6 or as close as possible, but really focusing on any reduction in NTSB. And then looking at participation of hospitals with higher NTSB rates. That's our nulliparous, term, singleton, vertex population, so the lowest population for cesarean rates. So looking at the disparities that might exist, some of those outlier populations at different racial groups. We're trying to increase community and patient awareness of existing racial disparities and causes of NTSC cesarean delivery, and really trying to share some of these engagement practices between patients and communities, informing the adoption of equitable care practices in California. Some of our curriculum education and training looks like monthly coaching, providing education and capacity building, really honing in some of these quality improvement fundamentals, reviewing baseline assessments like patient-reported experience measures or cultures of safety, cultures of equity, reviewing a lot of the fundamentals in implementation science, for the principles of respectful care, listening to your patients, engaging community, what that looks like, and then really technical assistance in leveraging other tools by CMQCC, such as our Maternal Data Center and our Hospital Action Guide for Respectful and Equity-Centered Obstetric Care. To really give some structure around these 18 months, because it's a long time and a lot of material to cover, we're doing quarterly webinars on both health equity topics and cesarean rate reduction tools. So we are coming at it from all sides, trying to provide as much education and capacity building as possible. And the reason we're titling this webinar as Building Blocks of Culture Change is to highlight that this is a long-term effort. This is not something that happens overnight. 18 months is a long time, but even that is not enough to really establish this work. It is the baseline, it is the setup and the starting point. It takes a long time to shift culture towards one that supports, promotes, and really embodies respectful care. It takes testing, iteration, those PDSA cycles, to explore what are the different building blocks that are going to make a difference on your culture, on your unit, with your team. The building blocks for one facility isn't going to be the same as the one for another. We're looking at what the different partnerships might look like. That might be culture surveys, humor, doula partnerships, community engagement events, sharing unblinded data, engaging in patient experience, patient advisory councils. So we are just sharing what some of those building blocks might look like for your facility that you can take home and learn and share with others. A little bit more about our facilities presenting today. We have Enloe Medical Center based in Chico, California. We have Tammy Newsome and Nancy Gagan, who are part of their quality and management team. And then UCSF with their partnership with SisterWeb, located in San Francisco area. We have Dr. Katie Brown, Marley Imistic, Ali Quintos, and Becca Amaral. So without further ado, I'm going to hand this over to Tammy and Nancy to get us started with learning a little bit more what Enloe is up to.
Hi, I'm Tammy Newsome from Enloe. I'm the perinatal quality coordinator. Enloe is located in Chico, which is about 2 hours north of Sacramento. We do almost 2,000 births a year, 1,900 to just up to 2,000. So that's pretty much our birth volume. And we are a privately owned hospital. So where we started, we joined the collaborative looking at how do we take our excellent NTSB management, ensure it's equitable across all racial and ethnic identities. So we participated in the CMQCC NTSB collaborative back in 2020. So we had already done quite a bit of work with NTSB, but when we joined this collaborative, it was more about looking to see if all of our interventions and initiatives were equitable. So one of the first things that we started with, and everyone did, was the implicit bias and implicit bias education. And when we started talking about that, we were kind of surprised at the number of staff that were a little bit offended and doubted that they had any bias. But by using the statistics from our stratified race and ethnicity data, we could actually validate the fact that there is a racial disparity. And the more education we've done around implicit bias, our team has become a lot more open to the concept. And this learning initiative really gave us a framework to look at all of our practices with an equity lens. So where we started, our baseline rate that we looked at from January 21 to December 22, our overall rate was 21.08%, so pretty good. But we found that our Hispanic population was 24.9%. So that was our goal, was to reduce that Hispanic population and TSP C-section rate to less than 23.6%. So what we're going to talk about today are some of the interventions that we incorporated during our original efforts for the supporting vaginal birth, reducing primary C-section, and look at those things that had value, and then talk about some of the new concepts that we learned when we implemented as we started working on the learning initiative. So one of the biggest impacts that of the changes that we made was the color coding of our grease board. And we started this with our original efforts in 2020, that we wanted to bring attention to our NTSB patients. And so we worked with our EPIC analysts to highlight those patients that were NTSB. And we ended up expanding this to highlighting our TOLACs, our twins. And originally, a lot of our staff and providers thought this was just way too much colors. But what we found is it really gave the whole team some insight as to what was going to be happening for the day. So when we look at a board like this, percentage was the color we chose for NTSB. So we know that this is going to be maybe a longer day. We're going to be more patient with these patients. We're not going to expect them to deliver like a multip would. Same kind of thing with our TOLAC. So the green is our color for TOLAC. And that just gives everyone on the team a little heightened awareness that is someone who's attempting a TOLAC. So this has been really effective and easy. And it also really demonstrated a lot of staff engagement after we had worked with this for a while. So now when we have a blue board, people get really excited. This picture on the right was sent to me over the weekend or when I was off, and they covered the names because they were so proud that we had an all blue board that day. So the way we did this is we worked with our analyst and we assigned different colors to different patient groups. To mark them, though, the nurse actually has to go in and click on the patient and then assign the LND status. This also helped us with our education as to what NTSB is, because to be honest, back in 2020, when we first really started working on this, not everyone was really clear on what that actually was. So it's helped us in a couple of ways.
Can you hear me?
Yes.
Okay, so my name's Nancy, and I'm the director for the Mother Baby Care Center. I'm going to present this slide here. We administered a culture of equity survey in the early months of the initiative to establish a baseline understanding of what our staff knew and how they felt. We assigned the survey in our hospital learning system for all of our staff. For our providers, they're not enrolled in our LMS system, so we provided them with a paper survey. And you can see the QR code there sent them to the survey and gave them the opportunity to complete those questions. We're grateful for Savannah, who reviewed and then correlated our results with actionable items from the Hospital Action Guide for Respectful and Equity-Centered Obstetric Care. And this helped us guide us in our next steps and where we were going to go forward.
Another survey that we implemented with the help of the initiative was a PREM survey, or the Patient Reported Experience Measure. And when we first started talking about this, it seemed like it was going to be really hard to implement, and we weren't really sure how we were going to do it. And working with CMQCC, there were different avenues of doing patient-reported experience measures. And we ended up going with our hospital-wide. We have a survey format that's called WUFU. And so we ended up hosting it on our hospital website. Or not, it's not our hospital website, but it's a link that goes through our hospital. And we have a QR code. So we have our patients, they can scan the QR code and take it on their phone, or we also have it loaded onto the iPads that we hand out to patients for patient education. And it took a lot of back and forth with the administration, because we needed to be sure that our questions didn't overlap with HCAHPS, because we don't want to be giving our patients too much of the same survey type things. You can go ahead and advance the slide. So we used this process checklist that was supplied to us from CMQCC, and it was really helpful in keeping us on task because it did ask that we look at all of these different aspects in implementing the survey. And it really did keep us on track as to how we were going to do it and what we were going to do for like the communication plan and the patients to be included and the staff to be included. So this process checklist was really helpful for us. Once we got the survey built and hosted through our website, we had these cards made and with a QR code. So this is what we can hand to the patient that they can scan, or like I said, it's on an iPad. And when we first had this built, we were so excited because we thought we were almost there. And then we realized it's in English and we really need to have it in other languages. So then we sent it back and had it translated into Hmong and Spanish because those are our the bulk of our non-English speaking patients. And when marketing first sent that back, they had a white woman and a white baby. And we have just become more aware of really changing up our marketing and the pictures that we have to make it more inclusive. So we were able to work with marketing, and I think they're learning a little bit about equitable care just from this experience. So overall, it took about 6 months from the first email to the administration of our first survey until we got a response back. And when we were working on the questions, CMQCC had some example questions that we could use. And we took those questions and met with our birth equity team, which was comprised of some staff members. And we really went through each question and we tailored it a little bit to really find out what we wanted to know. Questions 8 and 10, we really called out to patients if they felt like they were treated negatively, not just differently. I think the original question was if they felt like they were treated differently. We really wanted to know, like, do you feel like you're being treated negatively? And then question 11, we have a free text portion, and that's been really valuable to us to get just feedback from patients and how they feel. So we share those comments with the staff every month. And then question 15, if they would like us to follow up, they can put their phone number and we can follow up with them to talk about opportunities or things that we could have done better. And that actually has been really helpful. We've had a couple of things come up that we were able to talk to the patient, have the provider talk to the patient, and kind of process what happened during their birth.
When the survey was completed, an email was sent to Tammy with the results. As you can see here, there are some of the results that we shared. We have been receiving overall positive comments, but we did occasionally and still do receive a response that provides us with an opportunity as a team. If follow-up is needed, the leadership team reviews and then develops a plan. Some of the comments that come in, like Tammy mentioned, they do identify themselves, so it gave us an opportunity to speak with them. Others were anonymous, and those situations we needed to develop a plan and work through some of those concerns that were expressed. Comments are then shared with our staff monthly for an opportunity for them to celebrate the good work our team is making, as well as an opportunity for individuals to reflect on their practice, their personal practice when opportunities were expressed. And you can see here several of the comments, both positive and negative, that our patients shared with us.
Another method that we routinely use to facilitate staff engagement is humor. Back in 2020, when we started working on NTSB, I would post the graphs from CMQCC with the bars and the just all of the different data points. And I found that people weren't really paying attention to that. So then I started trying to think about other ways to get people engaged and to actually look at the numbers. So this has been just a really fun way to get people to pay attention. And it kind of bridges the divide between different generational learning styles too. You try to do like the Ken, the Barbie, and then back to Star Wars, just to grab people's attention and get them to pay attention to what we're doing and where we are. So for us, we felt that humor is attention grabbing, and that when we laugh, the reward center of our brains is flooded with dopamine. It makes it more engaging, and we feel like it gets for better long-term retention. And I actually found a quote by Matt Abrams from Stanford. Humor does more than just make people laugh. It allows you to connect with your audience, diffuse tension, foster trust, and compel others to your point of view. Humor can also help you and your message stand out. And we've definitely found this to be true. They love all of the silly things.
So this slide has photos of some of the interactive posters that we put up in our staff conference room. These posters allowed staff an opportunity to reflect on several of the different subjects that we learned during the initiative, such as microaggressions or equality versus equity. The Committing to Respectful Care poster that was in the center was near the beginning of the initiative. We were excited to see the engagement and commitment of the staff. This was a simple poster in which the employee could pick something that they were going to commit to ongoing throughout our initiative and participation. And it was fun to see and hear staff talking to one another about the posters, and some of the discussions that took place really helped others become aware of the opportunities that we had as a team. Our department has developed, we've had these patient education booklets for many, many years. They are seen here. You see the pregnancy planner and the going home booklet. When you take a first glance at this, when we looked at it, it was interesting going through the process of the initiative. So many of our pictures were that of, like Tammy had mentioned, white women and their babies. And so it gave us an opportunity to really reflect and take a look at all of the things that we were producing for our patients. Anyone can access these booklets. Patients are given these at the beginning of their pregnancy and or at the time of the delivery, but they're also available on our Enloe Health website, both in English and Spanish. And so as we continue to move forward, developing educational pieces and with our website, we are becoming more aware and working with marketing on being culturally sensitive with our photographs and with our languages available.
So this is titled What Worked at Enloe, but I thought more about this, and it should actually be what we tried at Enloe, because not all of these things have actually worked. And this is our ongoing effort since 2020. So this is a list of all of the different things that we've tried. And I do have it broken down for nurses and staff, and you'll see on the next slide. But I just wanted to talk about a couple of things that we've done that didn't. We tried to do candy bars for every NTSB vaginal delivery. And then I did candy bars for anybody who had an NTSB patient that turned in the labor dystocia guidelines. And that didn't really prove to be sustainable. We had little signs that we put on the doors of all NTSB patients, and that didn't really work. That wasn't sustainable. The grease board colors kind of took over for that. We tried to do shift champions, where every shift we would assign an NTSB champion who was supposed to have the lower acuity patient, and they would be the one who was keeping an eye on all the persimmon patients and offering suggestions or helping with position changes. But that was not sustainable. We tried to have scheduled pushing breaks from one that was pushing with their patient for a long time, even so detailed, like every 20 minutes, someone was going to be checking in, and that really wasn't sustainable. So we've tried a lot of different things, and some were not sustainable, but other things were sustainable and effective. the labor dystocia guidelines, we have those on the back of what we call our labor brain. So we have it's like a worksheet that people can organize their care on. And then on the back of that is the labor dystocia guidelines. We already talked about the grease board, color changes. Other things that we've done are that we did labor support workshops. It was an initial really intensive training. And now we've done spinning babies trainings every year. Essentially, we bring spinning babies here to Enloe, and that makes it a lot easier for the staff. You can go ahead and move to the next one. We did a new scheduling form for our clerks and for our providers, but our perinatal clerks are called the scheduling form, which now we have built into Epic. We tried to do education with patients on "Oh, baby, is it time?" Adding to the discharge instructions, just going with that. It's so helpful for patients to stay at labor at home as long as they can. We have labor support videos. We actually work with marketing to help define NTSB for patients. For providers, we did a lot of education on cervical ripening, on different techniques for ripening, including outpatient. We had manual rotation education by Dr. Juan Vargas. We did some strip review, and then we also review our data with them. So all different angles. So where we are now, I have here our pre-collaborative rate, where the overall was 21.08 and our Hispanic population was 24.9. And post-collaborative, our overall was 16.3, which is amazing and great. But our Hispanic population, it was 23.4%, which was our goal, but there was actually a larger disparity. So that has just made us do a deeper dive into like, okay, we're doing great. We have our numbers where they should be, but there is a larger disparity. So we're really kind of looking into that and thinking about, do the Hispanic patients have equal opportunity to cervical ripening, that kind of thing. So we're just having to look more at it. But we're proud of our rate and where we are. And this all hospitals graph has been a great tool for us, because before we started in 2020, we were on the far right of that graph.
So moving forward, we plan to continue to administer the PREM survey to patients and share those responses with staff. We plan to utilize a checklist that we developed during the initiative that helps us keep equity in mind when we are reviewing our policies within the organization. In our marketing and any visual display that will be presented on their unit, we are ensuring equitable representation in the items that we choose, in the pictures that we choose. We also are continuing to meet with our birth equity team once a quarter to review and revisit the work that we have going on. And like Tammy mentioned earlier, we look forward to ensuring we have equitable access to cervical ripening for all patients, and narrowing in particular with our Hispanic population, because that disparity has grown from our other populations. And then also we are looking at developing follow-up plans for birth trauma and using the guide for respect, or the action guide for respectful and equity-centered obstetric care to help us do that. And these are some pictures of our team that have been actively involved in this initiative. So thank you for allowing us to share our experience with you. Best wishes on your work with the initiative. I can say that your work will make a difference in the lives of your patients, just like ours did for our patients. Thanks.
Awesome. Thank you, Tammy. Thank you, Nancy. This was a great presentation. I know I have some questions to follow up, but I'll wait until the end. But thank you so much. We are so proud of you guys. You guys done a really, really awesome job, awesome, amazing work. So congrats, and excited for what's next.
Thank you.
Next, we have UCSF and Sister Webs. I will hand it over to you guys.
Good afternoon. I am Marley I. Mystic, one of the co-executive directors of Sister Web, here with my sister Allie Quintos, who's on the line. And we're excited to come and speak to you all about this collaborative, Crossing the Community Clinic Divide, and the impact and assessment of collaborative interventions for equity in maternal health. Let's go to the next slide. Our presenters and people who have contributed to this are actively in the community. Dr. Katie Brown in her absence with UCSF, myself and Allie. We do have Becca Amaral on the line to present in this, and we have our co-author, Dr. Nick Robuskin. Next slide. We have nothing to disclose. So a little bit about Sister Web. We started off in 2018 right here in the heart of San Francisco, and we've always had a focus on dismantling racist healthcare systems, strengthening the community resilience, and advancing economic justice for birthing families and doulas in San Francisco. But what does that really look like? What does that really mean? Well, on the ground, that means that we provide free doula support for Black identified families birthing in San Francisco. We also provide culturally congruent doulas who are community doulas with full-time benefited employment to provide this care for our clients. And within that, we know that the community wisdom is where the power is. And so from our very beginnings, we have trained doulas, trained community members to become doulas, and trained doulas to be even better doulas through our apprentice program and our what we call professional development or our core competencies with mentorship and advanced education. And one thing that always comes up is that we need to address what's happening in the systems that our families are entering into day after day, year after year, the same systems that our doulas are working in. And that's where it comes, this collaboration of the Champion Diet Initiative and the real improvement tool for addressing these racist healthcare systems. Next slide.
All right, greetings, everybody. My name is Allie. I'm the other co-executive director of Sister Web. So we wanted to highlight a little bit of our data from our past fiscal year. You can see 100% of our clients reported that doulas help them feel more confident navigating healthcare systems and understanding their rights and options. Give thanks for the presentation. We all just saw these reported outcomes are so critical, and our doulas are key in delivering care, and then also SisterWeb collects patient-reported data as well. So 100% of our SisterWeb clients reported that their doulas helped them use their voice, assert their own wishes, and ask for a moment when they needed time to think over a decision, which we know is a key component of informed consent. We also are tracking metrics related to the doula's own experience when they go in and work in the hospital setting. 100% of our doulas are peer support people, so they represent the same client, the same community as our clients. And we track these metrics every month. So a real focus on repetition and consistency when collecting data. You can see below, SisterWeb clients had a lower percentage overall of preterm births compared to the California average and San Francisco City and County data when it comes to the same demographic that we are serving, which are Black African American families. Next slide. The Champion Diet Initiative. So Marley, I mentioned this is one of our many programs in addition to our direct service, doula programs, our workforce development programs, training in the community. We knew right from the beginning and actually started this initiative before we even attended our first birth. So back in 2019, we said we are training community members to go in and support their peers, their neighbors, their cousins in the hospital setting. We know harm is bound to happen, right? And so the Champion Diet Initiative was a premeditated, very intentional initiative to really have it be a collaboration, right? We knew we can't change the system alone. So Champion Dyad refers to a community representative, so in our case from SisterWeb, and a representative from within the healthcare setting, of which Rebecca, who's here from UCSF, is one of them representing her hospital. Having tracked this initiative, now we're going into our 6th year of the initiative. We have very robust data, both internally collected and working with external evaluators, our research cousins over at UC Berkeley. We've been able to track the efficacy of this method, and we're in the process now of offering it as a replication to other counties and healthcare systems here in California and even in other states. We have also been included in AmChip's Innovation Hub as a best practice. Next slide.
So what does the champion dyad look like on the ground? What's important to it? How does it work? So it's really about leveraging relationships. As Ali said, we knew early on that we were going to be seeing the same people going into the same hospital rooms over and over again as birth workers. And so we take that and take it to the next level to actually build connections. We have committed champions inside the medical institutions who are dedicated to coming every month and sitting with our champions inside SisterWeb to discuss not only what's happening with the clients, but updates with the hospitals, what happened with the latest birth, what care is needed, true care coordination, true warm handoffs, true creative inquiry about how we can best serve our clients. And this comes from the data that we receive from each time our doula is working with our clients or attending a birth. And we're able to give bi-directional feedback to improve the relations. And also see where there's areas where there may be a need for some more collaboration, whether that's in trainings like we've been able to do with our doulas and with some UCSF staff to be able to have shared learning and learn that we're all part of the same team. And this collaboration and the close working relationship and the time is what really makes the change. Next slide, please. So who are we working with and how are we getting our referrals? Like we've said before, we work with all the birthing locations in San Francisco. So that's UCSF, General Hospital, Kaiser, the Birth Center, and CPMC Sutter Health, each one of those having champions who are dedicated to improving the quality of care for Black and Brown families in San Francisco. And you can see in 23 and 24, we had 214 referrals. And the majority of these referrals do come from the birthing locations. We know that the champions and the providers in these CDI locations are dedicated to bringing quality care to their clients, and they understand the power and value of having doula support. Continue on, please.
Okay, so these are some of the metrics. Again, we feel like it's fundamental to not only track our data, but make it visible. All of this is available on our website. That total number of meetings between CDI reps, 45 meetings in 1 year. So just pause, because I know people say, not another meeting, but we know this is really the special sauce. How do we get these great outcomes? How do we make change? We have to keep coming back to courageous conversations that are built on a foundation of trust. And that is built through relationship, fellowshipping, events, meal shared, right? Having to come back and say, wow, that was a really tough interaction. Are you ready to talk about it? Not yet. Let's come back next week, right? And so the other pieces are care coordination. We know doulas are not here to replace the medical staff. We're here to work in tandem. So there's a deep, deep, deep respect, and I would say even love, because we're all wrapping around our families, providing them the most excellent care. Next slide. And here you can see, besides the quantitative data, we also collect a lot of qualitative data. I loved reading the quotes in the other presentation. I'm kind of a qual data junkie, and so I was like, hey, yay, let me read these quotes. Again, like our other presenters, it's a mix of positive feedback and critical feedback, which we really use as gifts. Every piece of feedback is an opportunity to address it, do better. And I will say that over the years of the CDI, we have developed a tool, a tracking tool, to actually take every single piece of feedback in what we call our accountability tracker and actually see what happens. So how many of us have filled out a survey? We pour out our heart, write that comment, and then it's like, goodbye, it goes off into the world. Well, we know that when our clients, our patients, our doulas report things, experiences, negative experiences they've had, we want to be able to come back and say, somebody actually did something with this piece of feedback. And that takes the collaboration of both the community partner and the clinician working in tandem. And I am going to pass it on to our colleagues from UCSF.
Hi, my name is Becca Ameralt. I'm one of the midwives at UCSF, and I am thrilled to be part of the CDI program. I've actually been a member of the CDI program since it started in 2019. I was at that very first meeting, and it is one of the pieces of my job that really fills my soul. So a little bit about us at UCSF. We're an academic tertiary care center in San Francisco. We do approximately 2,500 deliveries a year. We are a collaborative practice, so we're a group of midwives midwives and doctors on labor and delivery, and nurse practitioners in the clinic and in postpartum. And we do have a really long relationship, UCSF and Sister Web, is not just the champion dyad, and so we're really lucky to get to collaborate so much with them. We have our monthly meetings with our Sister Web collaborators. They're attended by myself, as well as one other midwife, Dr. Katie Brown, who's one of our MDs. We have a nurse from Labor and Delivery, Carla, who attends the meetings, and then a patient navigator as well. So we're a pretty robust group meeting for these monthly meetings. But I think the piece, and this is what Ali was just saying, is that having the meetings is just sort of the baseline of what we've built our relationship on, so that we can continue to have important conversations both in these meetings and outside the meetings. I totally agree it is the special sauce, and I'll talk a little bit more about this later, but one of the things that I love about the work that we're doing together is that what it really takes is time and dedication. And so you don't have to be the quality director. You don't have to have a big title. You have to have decided that you're willing to put the time and energy into this project and be dedicated to it. And that's really all it takes. And I appreciate that. So the CDI really does allow us to take care of patients in this multidisciplinary team. It means that when there are things going on for my patient where I know that they're better served by their doula communicating with them about it, that I can communicate that I would love for their doula to have more of a conversation, can communicate that to the patient because I know that their doula is more than capable of talking about non-pharmacological pain methods or any of those other things that we may not have time for that in my visit. The CDI also allows us to work together to take care of patients that have complex histories and complex relationships to healthcare, which is, I think, something that we don't always address in our hospital-based care. Next slide. So the gift of feedback. I cannot emphasize enough how helpful, and I apologize, I've been speaking all morning, I'm in clinic, so sorry if I'm stuttering a little bit here. So I cannot emphasize enough how important the feedback that Sister Web gives us is. It is so valuable to us. We get long, lengthy information packets for each patient where we can really dive into it and go into details of what is happening for our patient. So it's so much more than any sort of quick survey. So this is sort of a typical shorter version of what we get from each delivery. So we get a clinical scenario, which is usually longer than this, but we shortened it for this. In this particular case, it was an induction for suspected prom, and then we get celebrations. And what's great is I can take these celebrations and I email them directly to the person that was celebrated, as well as their immediate supervisor and the head of labor and delivery, so that everyone gets to celebrate these phenomenal providers, nurses, midwives, anybody who is taking good care of the patient. And then we get the critical feedback. And so some of the time we get things that are little details that are important for us to address. And sometimes we get really big concepts that are going to need more than one conversation to really dive into. So, in this case, it was some communication. So the provider didn't, first the client felt like there were too many people in the room and that wasn't addressed. And then that the provider didn't really give explicit information about what they were doing with the repair. And so we're able to take both of those pieces of information and look at what are the systemic issues, what are the things that we need to focus on as an entire group, and if there are some bits that we can just direct to an individual provider. Next slide. So what we did is right, there was this formation of Sister Web and the CDI. We got all of this rich feedback, and a group of us, and I know Dr. Rosenstein is on the call as well. She was a big part of this group. A group of us looked at this feedback and thought, we can't just take this in and give little bits and nuggets here or there. We really need to have a larger picture of what kind of care are we offering to our Black patients, and is it the type of care that they deserve and that we want to give? And so from that feedback, we developed the formation of the Black Birth Equity Collaborative at UCSF. And that collaborative deepened our relationship with UCSF and Sister Web and deepened the collaboration. And in fact, we recently just were given the ability to hire both Allie and Marley on as contractors to help us with a little bit more of the deeper dive into how the sausage gets made, to help to fix some of our internal issues. So I'm really excited that that collaboration continues. And the other thing that it's done is that we've taken a lot of the lessons learned, and we have made a co-facilitated training about consent and respectful care that we give as a group. So myself, Dr. Katie Brown, Allie, Marley, and Dr. Rubashkin give this this training on consent and respectful care. Next slide. This is the Black Birth Equity Collaborative, and these are the members on our task force. And one of the things that I am going to talk about is in terms of our facilitators, which I think is on the next slide. Go ahead, next slide. Oh, this is barrier. I'll do barriers first, and then we'll get into our facilitators. So some of the barriers to the work of this collaborative, obviously the biggest one is institutional systemic racism, and that we have to address it head on. We can't hide from things. We can't put our head in the sand. We have to really be able to own the piece that we, as the hospital part of the CDI, are responsible for that institutional systemic racism. That is on us. Change is hard, especially in medicine. There is limited time and funding for the committees to further their work. And so that is a piece where, again, as I said, you need time and dedication. And so knowing that this is going to be something that takes time, that takes energy, and that it is more than worthwhile, it is necessary, it is our responsibility, it is what we have to do. We have to make the time and energy for this. And then different levels of priorities amongst providers, nurses, and staff. There's a piece where while this might be my top priority, it may be someone else's 5th or 6th priority, and continuing to move that conversation forward about why I have to convince people of why this should be their #1 priority. Next slide. Some of the facilitators to the work, and this is one of the things that I wanted to say when I was showing the Black Birth Equity Task Force, is that our chair, Dr. Andrea Jackson, has really been behind this work from day one and has been involved with Sister Web even before she was our chair. And I know that this makes it sound like, oh, this is just so easy. Then we have a chair who supports us. And while it doesn't make the work easier, it is a huge facilitator that we have leadership behind this. And I know how hard that is for practices where leadership does not feel the same way about doing this work. We are really lucky that our chair and other members of leadership, including Dr. Rosenstein, are really behind this work. There also are multiple programs at UCSF that are dedicated to Black birthing people. So we have the Embrace program and the Black Wellness Clinic, which are both programs that are run by Black providers for Black patients. CMQCC is listed here as another facilitator of the work. We are really grateful to CMQCC. And then obviously the CDI is a facilitator. Next slide. So our work going forward, as I said, we have this brand new contract, which we're excited about. We're also expanding our partnership with Sister Web. We have a deepening collaboration with the CDI that continues, and a framework for for quality on labor and delivery. We continue to do events with our staff towards culture changing and anti-racist obstetric care. We also do work to bring people together so that, as Ali said, sharing a meal is always big, right? So bringing the sister web doulas onto labor and delivery, which is always important in a social way. And then the accountability piece. So there's a lot of self-reflection, change, humility, time, and ongoing work. And I think that, you know, when Ali talks about the accountability tracker, like that's been wonderful for us. So we really can look at the information that we've gotten in our CDI meeting and take that, come back to the next CDI meeting with the list of these are the people we talked to, these are the things we did. And the policy changes take longer, right? And so it is a month by month review. Okay, so we had this conversation with the head of anesthesia and they are going to look into this and then we're going to get back to you on this. And it might be 6 months before we actually have any sort of protocol or resolution, but that's how the revolution happens. So so it's just continuing on with the long-term ongoing work. Next slide. So this is the consent that we hold, as I said, co-facilitated by all of us. And we've done it a couple times and it's been really successful and it's a really fun workshop to get to do all together. Next slide. We also have created a commitments to respectful care, which came from the Black Birth Equity Task Force. This has actually been Dr. Rosenstein's child that she has birthed recently. So we've come up with these 6 different commitments to respectful care, and then a lot more information on each one of what that means, what UCSF specifically is doing to bring that commitment to our unit. Next slide. So this is an example of one. So for informed consent, we promise to answer all your questions and provide clear information and explanations. We promise to ask for your permission before engaging in any procedures, physical touch, or communication to others about your care. And then we have, when we're presenting this, we have examples specifically from patients, often from sister web patients, of where this comes into play. And then small group discussions every time we go over this. And these commitments have been approved by everyone on our unit, leadership, individual providers, nurses, nursing leadership, individual nurses. Really, this has been a huge project and undertaking to make sure that everyone is dedicated to this. Next slide. We did an M&M presentation on the commitments to respectful care recently, which was very exciting to present all of this. And we presented specific cases, as I said, many of them coming from Sister Web. Next slide. That's our contact information. I think that, I'm not sure if we're doing questions right now. Yeah.
Yeah, we've got a few preloaded, but I want to say thank you. This was an amazing, amazing presentation. Huge kudos to both the UCSF team and the Sister Web team. You guys have really driven it home and done an excellent job. So congratulations. It's a huge accomplishment what you guys are working on. We have a lot of facilities that we've spoken to, both within the Learning Initiative and around California, who have been working towards partnerships like this. So it's exciting to see something as established and with such good outcomes that you guys have had. So really, really excited for you. I'm going to, so if anyone has any questions, please feel free to post them in the chat or in the Q&A and we will field some of those. We don't have any yet, so please go ahead and submit some. But I do have a question that I would like to direct to both teams. First, if there's any unintended impacts, any side effects that you've noticed from either for NLO, any of the initiatives that you've mentioned. You know, we've had a long relationship with doing your culture of equity survey. If there's anything that you didn't anticipate coming out of any of those projects, or with the UCSF team or the Sister Web team, anything that you guys hadn't anticipated that you've seen as a positive outcome that weren't directly related to the project, but that you've seen over time.
I can, for NLO, one thing that came, well, lots of things have come out of participation in the initiative, but we have implemented an evidence-based screening tool for doing toxicologies on babies. So that was really exciting, just to be learning so much about just equity and equitable care, it really made us start looking at our past policy on which patients, which babies we did a tox screen on. So that was kind of an incidental improvement that we found. Another thing that we've been working on or learning more about is like the microaggressions and bullying, and working with staff that maybe are perceiving bullying from other staff. So we've actually done some more education on that. And that's just been, I don't know if our eyes are just more open to that kind of thing, or if it is a result of the culture of equity survey and people thinking about how they're feeling about how they're being treated. So we're doing additional educational, like little webinars kind of things on that.
That's great. Thank you for sharing.
An answer on our side. So the thing that comes to mind for me is that, you know, just like Ali was saying, sometimes you fill out a survey and it like goes out into space and you never think about it again. When the people from UCSF fill out our bi-directional feedback survey in terms of working with doulas, it goes directly to us. It goes directly to their colleagues, as well as to SisterWeb. And that was a surprise to a lot of people. And so I think that there is something that happens where sometimes when we are writing feedback to someone who we don't think is necessarily our colleague, we can be a bit dismissive. We can be potentially even rude about that. And when our colleagues learned that we were getting the feedback, when we came back to them with, you know, I have the thing that you wrote about your experience with this doula, let's talk it through. It really changed the communication. And I think it humanized the doula community for our providers in a way that that I think is really important. There's not a lot of great data that like providers are improving outcomes for patients, but there is really great data that doulas are. And so we have to hold that humility that that doulas are doing work that we're not doing as providers, and showing that respect is so important. And so I think that one of the unexpected bits for me is that I think that it has actually improved the way that our provider group communicates with doulas, because they know that they're going to be held accountable for the words that they say.
That's great. I think the communication is something that takes so much time to address and to change the culture around communication. So it's exciting to see that that's been an avenue that's had some positivity. We had a question.
I'm so grateful to be here. I'm going to have to log off because I've got a patient waiting for me, but thank you so much for having me. I've got phenomenal colleagues on the call who can answer more questions.
Awesome. Thanks for joining us, Becca. And we have a question in the Q&A for SisterWeb about sharing what payer networks SisterWeb is in network for, or is it a case-by-case basis with a letter of agreement? If you guys want to address that really quick.
Payer as in like insurance type of thing in network? Is that what this question is asking?
Mm-hmm.
So we are not in network. We provide free doula services for all of our clients. We are Medi-Cal and panel doulas, and we'll be doing reimbursements for it, but we aren't. We are our own nonprofit organization, and we provide this service through grants and contracts. That's how we're able to pay our doulas.
Okay, thanks. Peg's very excited about that in the chat. Big exclamation point. Okay, I think I want to ask one more quick question. If you had any advice for facilities that are trying to recreate or do something similar with engaging doulas, creating this partnership, identifying your NTSB candidates, Tammy, like you guys are doing at Enloe, or any of the other work around patient experience surveys, how would you encourage them to get started with PDSA cycling, with getting, starting this early testing and trialing what might work in their facility?
I can kick it off and then leave it for the other colleagues. I would say absolutely start with people who are closest to the heart of the matter. And so if you don't already have a deeply rooted partnership with a community organization in your area, that's your number one task for the day. That's your first homework. And then it can ripple out from there. And so instead of, what people say, recreating the reel, think about who you want to be your co-driver, right? And do it together right from day one. And I'll pass it on to others.
That's great advice.
I would say, and I have to tell myself this, to be patient, because so many of these things that we've tried, the initial reaction wasn't the enthusiasm that I had hoped for. But if you just keep picking away at it, eventually it gets there.
It definitely takes time. There's a lot of work. Dr. Rosenstein.
And I'll say, I'm so grateful to have Sister Web like as a organization in my community, right? And to have that partnership that is developed and exists, even outside of my work on labor and delivery. What I would say is if you look at that and you heard the Sister Web presentation, you're like, whoa, that's amazing. We don't have that. Again, I think really the idea is what it's also has changed for us is that we started meeting just with Sister Web, right? But now we have other doula engagements and we meet with the other doulas in our community that are independent. And so if you don't have, I think what Ali said is look for the organization if it exists and make partnerships with that. But if you don't have that in your community, I know that there are doulas in your community. And again, what we have found is, Tammy showed getting surveys directly, and we've struggled with trying to survey our patients, and we haven't been able to do that, I'll be honest, but we get so much rich feedback through the doulas. And so I think that's the other piece, is realizing that patients have such a strong relationship with their doulas, and they will tell them. And doulas have generally that's part of the model of debriefing and discussing, that is part of the doula model. So even if there isn't this partnership available and there's meetings that are already set up, then you can reach out to the doulas in your community and say, tell us what your clients are saying about us, so that you can build it up that own way, even if it's not as formalized. And maybe one day it will be, but really realizing that the doulas are such a fount of information that the patients don't feel comfortable telling us directly, but they will tell them. And if you have a good relationship with the doulas and they trust you that you'll take that information and not just put it down the chasm, but you'll actually do something with it, then you'll be able to hear it.
Absolutely. That accountability piece is so important. Well, thank you so much for those great advice, for all those tidbits. A lot of people are working on this and getting started, so it's exciting to see what can happen when you keep trying and keep testing different things. I want to thank everybody for your time. I know we are at the end of things, so I just want to remind you we have future webinars coming up at the end of July and the end of August. We'll continue this conversation around what engaging doulas look like in the community, advocating for patients, engaging your staff, engaging your leadership. There's a lot coming down the pipeline, so join us. You can register at cmqcc.org. If you're interested in joining a Learning Initiative cohort, email us at info@cmqcc.org. We will be launching rounds 4 and 5 in the fall and winter this coming year. Only for our California hospitals, unfortunately, but we have lots of resources on our website. So you can engage with us in lots of different ways with CMQCC. You can follow us online, and we are excited to have you, and we will see you guys next time. Thank you so much for joining us, and we will see you guys next month. Thank you all for joining. Thank you, our team, and have a great week, a great 4th of July.
Thanks, everyone.
Thank you, guys. Bye.